disease control is a thing, but complications are an important part of concern for the cars. What we see is that probably that with time, the teams have improved in terms of patient management, risk assessment, prevention, early measures to temper with the CRS and ICANS. What we can see on the last years is that the toxicity is progressively going down because we are improving ourselves.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I am your host, Isabel Olivera. In this episode, we explore what real-world evidence and patient registries are revealing about CAR-T cell therapy, who actually receives it, how effective is it, and how toxicities are playing out outside of clinical trials. Joining us, we have Professor Benoit Tessoulin. He's a hematologist from the hematology department in Nantes in France. He's a key contributor of the DESCAR-T registry, and he's here to discuss with us what this data means for your repairs and day-to-day decisions. So thank you very much for being with us today.
Thank you for having me. Great opportunity.
To start, can you please introduce yourself?
Yes, I'm Prof Benoit Tessoulin. I'm the head of the lymphoid department in Nantes University Hospital in France. I'm also a member of the LISA group.
We want to understand how registry data is helping with CAR-T. There is this registry in France. Can you explain what it is, which data is being collected?
Yes, so DESCAR-T is a very massive effort that we had to produce in order to register every patient who is deemed eligible or who should receive CAR-T cell in France. So the system has two phases. The first one is not relating to science. It's for reimbursement of the CAR-T for the hospitals. But the scientific part is about collecting all the data of the patients anonymously and to prospectively follow the patients along the journey, whether or not they receive the CAR-T cell, so that we have a common denominator, all the patients, and we can focus on patients receiving or not. And doing that, we can conduct some sub-analysis, looking at prognostic factors, either for success, but also for toxicities. And we do that in lymphoma, ALL, and multiple myeloma as well.
How do you compare the data in DESCAR to other registries? Do you compare data and do you share the data?
Yeah, so we can share data. The granularity of the DESCAR trial, that it's a lapsus because DESCAR works like a trial CRF, right? It's really a complete report form for every patient that is uploaded by the teams. It's not some little work. It's time-consuming for the teams in their centers. So there is a lot of details in the DESCAR-T. And DESCAR-T not only registered injected patients, but patients who won't be injected with the CAR, which is quite unique to be sure of what is the denominator of patients. So CIBMTR has a very big strength compared to us, is that the numbers are way higher than ours. The granularity is a little bit less, and especially regarding some toxicity, etc. So when we are doing some comparisons, we know that there are some variables that we can only look into our data and not the other data sets.
Why are patient registries in general so important in CAR-T? What do they capture that trials cannot capture?
So the first obvious reason is the numbers, right? We have registered something like 2,000 patients in DESCAR-T, which is quite a lot compared to any clinical trial. So the numbers are very important to be sure that what we have been seeing in some clinical trials in terms of, for instance, prognostic factors can hold into the real life. So that's the first point. The number is important because it will capture the heterogeneity of the patients that may not be the heterogeneity of clinical trials, or which we know there is some strong bias towards not better, but patients who are more keen to be successful with their treatment with less toxicities.
So in your view, what would be the main things that real-world evidence has added to our understanding of CAR-T therapy?
The straightforward answer is that we can answer some questions that industry doesn't answer. They won't conduct any clinical trials to answer to some questions. for instance, comparing one product to another. Those trials, they don't exist. So within the DECAP trial, we can compare head-to-head some products. And that's probably one of the main takeaways from now that has led to substantial shifts in use of some products for some patients.
From what you see in practice in these registries, how different are real-world CAR-T populations from the registration studies?
So that's a good point. And I think that we follow up with another question on similar, but not exactly the same. Are the results on par, or are they similar to what we see in clinical trials? That if we focus on patients in real life, what we have seen is that, for instance, when you take the bridging therapy in CAR-Ts, bridging therapy was very, very uncommon in many trials that led to approval of CAR-Ts. Because when you look at the large B-cell lymphomas, because it's the biggest database that we have, almost every patient has went through bridging therapy. So that's a very, very big gap between the two concepts of real life. Those patients, most of the time, they cannot be waiting for some leukapheresis and then wait for the products, etc. Well, in clinical trials, there is a bias towards patients who can wait and who don't need bridging therapy in most of the cases. And this is a very big difference among patients, because those ones have higher tumor masses, higher volume, they are inflammatory, they are cytopenics, etc. So the real life setting is really different from the clinical trial setting in terms of getting the patients to the product of leukapheresis. Yeah. So that's a big difference.
So you have a more heterogeneous population. Often the patients are more advanced. That's why they need bridging therapy to wait. What are the response rates then in this case? What do you see in these registers as response rate?
So that's what is beautiful with CAR-Ts. When we started the registry, we had some fears that we would not find the same results that in the clinical trials, because we were kind of aware that the patients were different. But at our surprise, I must say, CAR-T is probably the only one where the clinical trial results really do look alike what we see in the real life setting. Even if the patients are different, even if they are more prone to disease progression, etc., before injection, what we see is that the numbers that we have in terms of disease control on the long term, they're really, really similar to what we see in the clinical trials, which is reassuring, right? But so that's probably the key point for us. And in terms of complications, because disease control is a thing, but complications are an important part of concern for the CARs. What we see is that probably that with time, the teams have improved in terms of patient management, risk assessment, prevention, early measures to tamper with the CRS and ICANS. But what we can see on the last years is that the toxicity is progressively going down because we are improving ourselves.
What has the registry data taught us about late versus early CAR-T failure?
What did it find out is that we cannot really be sure of why the patients are failing the CAR. Of course, there are some obvious reasons that some patients are going to fail their CAR-T therapy, but so far we could not find some strong points saying that even the real life data that if the patient has progressive disease and if CRP level is as high, okay, the risk of failing the CAR-T cell is important, especially in the early setting. But for now, and according to what we see, we cannot say that it's a hard stop for those patients, because a fraction of them, even having all the tick marks in the wrong cases, they will behave quite well and respond to the CAR. So for now, what we can see is that, of course, there are some prognostic factors in the late and early progressive disease after CARs, but that does not prevent us for now to inject patients with their CAR-Ts when it's available, because patients will benefit in a high number of cases here.
You touched on toxicities, but is there something special that has been revealed about toxicities by the registries?
Yeah, the registry has come up, but DESCAR-T is not alone in the field, right? There's the CIB MTR, there is the Spanish registry, both of which are very rich in number of patients. So there has been a signal towards some T-cell malignancies after CAR T cells because of the way the product is made. But for now, we have been describing some cases that may relate to the CAR, and it has been proven to be related to CARs in some cases, especially a myeloma, for instance. But these are very rare events. In the DESCAR-T registry, the previous analysis that had been published, we didn't see a strong signal towards this. And so for now, we keep our confidence into the products, and we don't see an alarming, increase of this kind of neoplasia. So for now, these kind of toxicities, they are very, very rare, almost unique. And for the other toxicities that relate mostly to leg infections, for instance, that's something that teams around the world who are using CAR-Ts, they have not been waiting for DESCAR-T to guide them. And all the teams, they are now doing quite nicely. And we see that the infection rate has flattened, and we know how to manage these patients well better than, let's say, 5 or 6 years ago.
So what you see is that the teams have learned how to deal with this much better.
Yeah, exactly. Yeah, and it's pretty nicely seen in the registry.
What about bridging therapy and lymphodepletion? What comes out of the registries?
So for bridging therapy, what we just learned is that for patients in second line, I bet that in the third line plus patients, it's the same. When you respond to the bridging therapy, you are doing better than the other ones. That not responding to bridging therapy should not be a reason to proceed to a second bridging to improve the response before injection. That is, if you are chemosensitive, okay, it's good for you. You're probably going to perform a little bit better. But at no point we advise with our data that the patient should at all costs be responsive before CAR-T. So that's a paper. I think to this date it's not published yet. It's been presented at ASH meeting last year, but that's our key point regarding bridging. If you're doing well with bridge, okay, but if it's not working, whatever, proceed with the CAR.
So you don't have to have under control completely the malignancy before you inject the CAR. If you do, it's better, but if you don't, still.
I mean, the whole point of CAR T-cell has been to give an answer to patients who were chemorefractory. So we expect them to be chemorefractory more or less. The less better that you should proceed to the CAR infusion.
How does timing matter? What has the registry data taught us about the referral strategy?
So that's something that we have been looking at lately, but it's somehow difficult to be sure how every center to center works. We cannot really get back to when the ID comes out from the first physicians who refer the patient, but we know that the shortest path is always the best one. That is, we need to see those patients very, very quickly when there is a signal saying that, okay, maybe it's not going to work with standard immunochemotherapy. So the shortest path is really the best one. And some timings issue have appeared on the screen regarding different products, because some products are longer to produce than others. And we know that it impacts a little bit the outcome of the patients. Or rather than impacting, it drives the patient selection. In some patients, we may wait for a little bit longer. They are selected towards some CAR T cells who have a delayed production, and the other ones, they are directed to the rapid CAR T cells. But we are talking of some days of differences, right? It's not that big, but we noticed in the registry that the teams were well aware of these tiny days and that they were shifting from one product to another in some patients rather than the others.
What comes out of the data and is applied to the choice between different CAR T products?
Yeah, so it started in 2022. There was a ASH presentation with Emmanuel Pachi who has shown some third-line plus VLB-cell data between Tisa-cell and Axi-cell, and the signal was really in favor of Axi-cell. And right after, because the tumor control was way better, even if the toxicity was higher, the outcome was more favorable for patients with AXI. And what we noted right after that, 6 months after, is that there was a massive shift towards AXI. And so that's first point. And now we have come to the second line, comparing the lyso cell and the AXI cell. Exactly the same exercise, but different echoes. And we are seeing similar disease control between the two compounds. But clearly, what everyone was expecting, right? It was not unexpected, but a more favorable safety profile for lyso cell. And that was quite expected. And so it's going to create some kind of momentum towards lyso cell as well now in second line setting.
CAR-T is recommended now for second line LBCL.
Yep.
And in other indications?
After the second line.
Okay. How do you think this would affect the registry data and what we can see there?
The second line setting has been on the market in France because only French centers are within DESCAR-T for several years now. So the registry just now filling up with new patients on a continuous pace. And so that means that when we are extracting some data from the DESCAR-T trial, we have the data from all the patients, that is, even patients who have been injected like 2 years ago, but the one who has been injected 2 days ago. So we have a median follow-up that is very short, so that we can answer on some very short-term questions and long-term answers too. But the DESCAR-T registry is not dying, so we are continuously enrolling patients.
Is AI helping to analyze this data?
Not yet. There is a very big, not that big to be honest, but very prolific statistical team behind all these analyses. And AI has not come into the field, but is going to come in the coming years because we are exploring some twins, virtual twins, not sure what it means to be honest, to help us fill the gap in some patients that are very rare. So it's not really AI, right? It's just statistics a little bit more fancy, but AI was not done it in tumor.
Is there something that comes to your mind that's important for the audience?
I think that the registry was an effort, and now that we are well aware that it helps us answer whether or not this product should be preferred to another, or whether we should conduct our clinical trials to come, we are very happy at the tool, and we are very confident on the data that you generate.
You want the audience to remember one thing about what real-world data tells us about CAR-T compared to what the clinical trial said. What would it be?
That in the CAR-T cell space, we can be confident in what has been said in the clinical trials because we confirmed it into the real world.
That's a great conclusion, that we can be confident of the results and we can still use them real world as they were recommended. So thank you very much for this interview.
Thank you for having me.
Thank you to the audience for listening. And if you enjoyed this episode, please like it and subscribe to our channel. Stay tuned for more episodes of EHM Plot.